The idea was born to build a smart stethoscope, one that combines hardware that is digital and amplifies sound, but also with machine learning algorithms to help the healthcare professional. And so this is an opportunity to introduce this early detection solution into any physical exam, particularly for pregnant women.
When a woman becomes pregnant, her health is carefully monitored for various risks. However, heart disease during pregnancy is not easily detectable. Researchers are now exploring how an AI-enabled digital stethoscope could help diagnose a weakened heart during and after pregnancy and help save lives. That's what we're talking about on this episode of Tomorrow's Cure, a podcast from Mayo Clinic that brings the future of medicine to the present. I'm Kathy Wurzer. Thanks for being with us. We have two guests today who are trying to incorporate AI into cardiovascular care. Dr. Demilade Adedinsewo is a non-invasive cardiologist and an assistant professor of medicine in the Department of Cardiovascular Medicine at Mayo Clinic in Jacksonville, Florida. She's interested in researching women's heart health and cardiovascular disease disparities. Also with us is Jason Bellet. He's the co-founder of Eko Health. That's a healthcare technology company based in Los Angeles that uses AI in its healthcare technology. By the way, in the interest of full disclosure, Mayo Clinic is an investor in Eko Health. It's good to have you both with us. How have you been? Thank you.
Doing great. Kathy, thanks for having us.
I'm doing very well too, Kathy. Thank you.
I want to kind of set the table for listeners, if that's okay, because, of course, we're talking about pregnancy. It's been called nature's cardiac stress test. I think you've probably heard that phrase, doctor. And it can be tough on the heart to be pregnant. Do we understand why cardiac issues can crop up during pregnancy?
So yes and no. There are a lot of things that we do not understand about pathologies that happen during pregnancy. And I would say this is unfortunate because a lot of cardiovascular clinical trials frequently exclude women, particularly pregnant and postpartum women, because of a number of challenges. We don't understand, how potential interventions can affect the physiology related to pregnancy and also during lactation. And we also have some historical concerns, about medications that were used in pregnancy that led to, significant adverse effects in the infants that, led to some laws and policies at the time, essentially banning pregnant women from participating in trials. So there's a long history behind this. But yes, it can be challenging to really distinguish between heart symptoms or symptoms of heart disease and normal pregnancy symptoms. There's a lot of physiologic changes that happens during pregnancy. We see increases in heart rates, the blood volume expands, and all of this can take a toll on how a woman responds to that pregnancy. So it's not often uncommon for pregnant women to report some symptoms that if they were not pregnant, you would consider heart disease symptoms.
Difficult to diagnose. It sounds as if it's a little tricky, especially I know that you are an expert with peripartum cardiomyopathy. What's been done in the past to try to diagnose some of these problems?
So great question. And I will try to talk a little bit or explain what does peripartum cardiomyopathy mean. So this is a unique form of heart failure that tends to affect women. Typically, we see it towards the end of pregnancy and in that early postpartum period. And what happens is that the heart function is essentially unable to meet the demands of the body, which is why we describe this as heart failure. So it won't be unusual for pregnant women to report lower extremity swelling, shortness of breath with walking minimal distances, or even getting short of breath while laying in the bed at night. So those are also classic and cardinal features of heart failure. So if a pregnant woman reports this, it is not unusual for the provider not to be concerned at first. So there really is a diagnostic gap there when it comes to how do we identify at a high index of suspicion and how do we make it to that diagnosis. Also, we do not have a simple, non-invasive screening test that is safe for mother and the baby.
So then I'm wondering, Jason, how might your device maybe help in diagnosing this?
I think Dr. Demi hit the nail on the head in terms of access to cardiology. And we certainly know in many countries, access to cardiology is certainly harder than it is here in the US. But there's over 40% of US counties that don't have a cardiologist. They do have access in many cases to primary care. And so the ability to take a low cost, non invasive tool like an AI enabled stethoscope, put it around the neck of a primary care physician who, when examining a pregnant woman, can run a reduced ejection fraction screening and identify early signs of heart disease that may have otherwise been missed, either because the symptom, as Dr. Demi said, was sort of misinterpreted as a regular sign of pregnancy, or simply because the patient just was not symptomatic at all. And so we really believe that this technology has the ability to improve access to early detection, which then can inform the patient to go to a cardiologist on a more expedited timeline and get the advanced care they need.
We're going to leap into the science, obviously, but I'm curious, Doctor and Jason, in terms of what drew you into this field. Why are you doing what you're doing? Dr. Demi, I'm going to start with you. When I've talked to other cardiologists, they say they got into the field because it's fascinating and empowering. What led you into cardiology?
I would say I have to completely agree with that. I think it's been interesting just to see how much technology has changed so many things that we do, in day to day life, how much we use technology for shopping, other activities outside of healthcare. And now we're starting to see the potential impact that novel technologies like artificial intelligence can bring to our field. So I would say that was one of the things that interested me and kind of made me want to, look into this a little bit more. How can we take some of these tools and improve the quality of care that we provide to patients?
Jason, how does an undergrad at UC Berkeley start a medical tech company?
Great question. A decade ago, my co-founders and I were students at UC Berkeley, and one of my co-founders was a bioengineer and really thinking about how we could use technology on the front lines of care to more accurately detect heart disease. And then talking to a number of cardiologists, the light bulb went off that the stethoscope is the icon of medicine. It's worn around the neck of over 30 million healthcare professionals globally, but it's a rubber tube in a lot of ways, and it relies on the subjectivity of the human ear. And so the idea was born to build a smart stethoscope, one that combines hardware that is digital and amplifies sound, but also with machine learning algorithms to help the healthcare professional better understand what they're listening to and analyze for a variety of heart conditions right at the bedside. But if we can just detect heart murmurs that much better or AFib that much better in the physical exam, we can then get those patients referred into cardiology faster, get the echocardiogram, and hopefully get the treatment they need earlier.
Say, would you do us the favor? Of course, we need to see what we're talking about, right? So, Dr. Demi, would you be so kind? I know you've got both a traditional stethoscope with you and the new digital model. So, can you explain? I mean, is it heavy? Most patients really don't like to have stethoscopes. They're cold. Can you somehow describe the old versus the new for us?
So, yes, I can. And I will show you an example of what your traditional stethoscope looks like. This is kind of like what we call the bell, that you place on the patient's chest. And this is the earpiece. And this is kind of like how you listen to the heart sounds. And it has this tube that connects it so that the sounds are transmitted from this portion of this device, the stethoscope, to your ears. And I would say that this one varies in terms of weight and how you handle it. The type of stethoscope that a cardiologist uses might be slightly different than one that a primary care clinician uses. In the ICU setting, if you're worried about infection control, there are different types that are used as well, like the disposable, very light ones. But yes, because of how this is made with metal parts, it can feel cold, and sometimes some physicians will warm them up before physical examination if that is needed. But otherwise, it's fairly easy and straightforward. And you place that on the skin, it's not harmful in any way. And most people are comfortable with using a device like this. If you would like for me to contrast that with the digital stethoscope, which is the device that has been developed by Eko, this is what it looks like. As you can see, it's very similar to the traditional stethoscope. The difference is that on this side, it has a little bit of a screen where you can see the patient's ECG at the time that you're examining the patient. And it also connects to our smartphone or tablet via Bluetooth technology. And you can visualize the ECG on there as well as the heart sounds. Another nice thing about this is that you can go back and play it and listen to it. And, it could be used also as a teaching tool for if you examine a patient and you wanted to have someone else listen to those heart sounds to see what they hear. In terms of weight, I would say maybe it's slightly heavier or about the same as the cardiology stethoscope that we use, but otherwise not very different apart from the fact that it has the screen and extra additional features that your traditional stethoscope does not have.
We wanted it to look and feel like a traditional stethoscope because it is such a familiar tool to providers and patients. But the power of the tool really comes with our smartphone application, where we capture 15 seconds or 30 seconds of heart sounds and lung sounds, send it up to the cloud, and analyze it using FDA cleared algorithms. But our vision is to create a pipeline of algorithms such that when you put the stethoscope on the chest in a future physical exam, we'll be able to take those 15 to 30 seconds of heart sounds, eventually lung sounds, and analyze them for a host of conditions, really turning that wellness visit that we all know with our provider that can be 15, 30, or 45 minutes into a really powerful early detection opportunity.
Heart sounds and murmurs are pretty complex. I know you both know that, and they're kind of dynamic in nature. So I'm curious as to how accurate AI is in classifying those sounds.
So, to begin with, when this technology was first released, one of the things that we wanted to evaluate is how well would it function in pregnant and postpartum women. So, we started with a retrospective study looking at existing data at Mayo Clinic for pregnant and postpartum women who already had a cardiovascular workup as well as an echocardiogram, which is this gold standard test and ultrasound of the heart that helps us measure the heart's function, and also had an ECG done. And what we looked at was how well does this artificial intelligence algorithm that takes data from the ECG predict the likelihood of cardiomyopathy. Then we moved on to a small pilot prospective study because there are differences when you look at data that already exists as opposed to new data that you gather. And that was when we first had the opportunity to record data with the digital stethoscope to actually look at the performance in pregnant and postpartum women. We had 100 women, 6 of them had a cardiomyopathy. And in that study, we showed also that the performance remained strong for this artificial intelligence algorithm using the digital stethoscope. And then the next step was how can we evaluate the impact of this tool on heart endpoints? So, clinical outcomes, does it actually improve diagnosis? Are we already doing a good job or not? And we decided to study this in Nigeria because Nigeria has the highest reported incidence of peripartum cardiomyopathy worldwide, reported to be as high as 1 in 100 live births in the northern part of the country. And so we conducted a randomized clinical trial. We enrolled about 1,200 women, with half of them randomized to have the intervention, which is screening for cardiomyopathy using AI with a digital stethoscope. And the other half was randomized to control, which is usual care. And in that study, we demonstrated that screening pregnant and postpartum women using the digital stethoscope powered by AI led to a doubling of the number of cases detected in the intervention arm compared to the control arm. And that is the study that was recently published.
You know, you mentioned that peripartum cardiomyopathy has a fairly high prevalence in Nigerian women. And I'm wondering, because I really hadn't prior to our conversation heard about this, is it prevalent in the United States? If it's not, is it just because we haven't really screened for it? And might this tool be helpful?
So that is another excellent question. We do have data on estimated prevalence in the United States, and it ranges depending on the study that you look at, from 1 in 2,000 to 1 in 4,000. Also, there are some additional studies that shows that there's a difference, among racial and ethnic groups, with prevalence being as high as 1 in 600 among Black or African American women. But to bring up the question that you asked about maybe we're just not doing a good job at screening, that is also very correct. Very few pregnant and postpartum women have a cardiovascular evaluation or any sort of cardiovascular screening or testing. So there is a school of thought that believes that we may not know what the true prevalence or true incidence of this condition is because we are not actively looking for it. And it's possible that there are many women that may have a milder form of the disease that still get through pregnancy and are missed in some way. Cardiomyopathy specifically is the number one cause of death in the late postpartum period, which is after 6 weeks through 12 months postpartum for women in the United States.
Just to kind of expand on that, one of the stats that is truly shocking is that Black and African American women in the United States have a 3 times higher maternal mortality rate than white women. And I think, in addition to the prevalence statistic, being able to improve access to this sort of screening in communities where there may be long echocardiography wait times, there may be fewer cardiologists, may also be a small step forward in sort of closing that gap. But it all starts with being able to detect that patient earlier to get the treatment that Dr. Demi is describing.
Jason is correct that yes, the maternal mortality statistics are actually quite concerning in the US. We've started to see an uptrend over the last 3 decades, and we do see this racial disparity where Black women are more likely to die during pregnancy and childbirth. Also, when we start to look at what are the reasons for maternal mortality, cardiovascular disease is the leading cause, and Black women are also disproportionately affected by cardiovascular conditions. When it comes to peripartum cardiomyopathy specifically, Black women are also diagnosed late. They present late and tend to suffer more adverse effects following diagnosis compared to white women. So, really, being able to identify the condition represents an opportunity for us to narrow that equity gap in diagnosis and care.
So, Dr. Demi, I'm curious, the study of the Nigerian women without, using any patient names or anything like that, obviously. Did you come across anyone during the course of the study that symptoms were detected and investigators said, oh, yes, this is an issue. This is something that this woman needs. Anything that popped up in the course of the study in terms of a real life story?
So, yes, I'm happy to provide an example of a woman that was diagnosed in the intervention arm at one of the sites where we were enrolling participants. And one of the comments I got from the site investigator, who was the cardiologist, was this woman had no symptoms. She had no symptoms, at least that's what she told the providers. And they were really shocked that she had a positive prediction based on the AI algorithm. She went on to have an echocardiogram and actually had a profoundly low ejection fraction in the 20s, so about 20%. So this was just not mildly dysfunctional, but severe dysfunction that could have been missed with standard clinical care because this was a pregnant woman but did not really have symptoms, might have been cleared by obstetrician and gone about her day-to-day life. And I think that this represented an opportunity for that woman to get plugged into care and for therapy to be initiated appropriately. Of course, that's just a single example. Our hope is that using technologies like this can help to reduce that time to diagnosis for many women and hopefully improve, maternal health outcomes.
You mentioned the echocardiogram. Thank you for that. Isn't it, a 12 lead ECG is what we expect when we go to the doctor's office or if we're in an ER or ICU, right? And I'm wondering, are you saying that the data gathered by the stethoscope is on par with a 12 lead ECG? Because I'm betting some cardiologists might be a little worried about that.
So that is a great question. And I wouldn't say that. I think it does something differently. So the 12 lead ECG is excellent if you are trying to identify specific cardiovascular conditions, including rhythm abnormalities. In cardiology, it also provides some additional information that you might not be able to get from a single lead ECG or a 3 lead ECG that is recorded with a digital stethoscope. But in the context of what we're using it for is whether we can identify heart failure early or not. I do believe that the digital stethoscope does a really good job with that. But going back to the 12 lead ECG, just obtaining an ECG is not enough in current practice for you to diagnose heart failure. You need the echocardiogram, which is why the artificial intelligence algorithm takes your ECG one step higher, provides an additional layer of interpretation that you don't get by just looking at an ECG.
I think on the topic of sort of efficacy, one of the kind of key elements of AI being incorporated into medicine, and I think a lot of folks unfamiliar with this topic may not assume that an algorithm is regulated in the same way as a device is, but if it's being used to inform clinical decision making or clinical care, it actually is considered software as a medical device. And so this algorithm had to go through FDA clearance. And then, of course, as Dr. Demi was referencing, has had multiple clinical validation and now a randomized control trial. But with respect to sort of the interplay with the 12 lead, we very much view this as an early detection tool that then would inspire a clinician to go get an echocardiogram. But most primary care visits actually don't include a 12 lead EKG or an echocardiogram. So this really, but it does include a stethoscope exam. And so this is an opportunity to kind of introduce this early detection solution into any physical exam, particularly for pregnant women.
I'm wondering, with this Nigerian study, is this a way that we can get more representative data to prevent AI biases?
It's an excellent point. And the answer is yes, which is I feel that we cannot overemphasize the need for thorough validation and for inclusion in anything we do when it comes to the use of these technologies. Before we say this technology is ready to be used in this patient population, we have to evaluate them and prospectively. So it's an opportunity to curate new data. It's also an opportunity for us to validate and potentially refine models. So if we found that this tool was not effective in that patient population, then we have a data set that can be used to refine the existing algorithm so that it works for the patient population that we want to use it in and potentially repeat additional testing to see if this is stable.
Jason, what more should be done to prevent AI biases?
Well, I think to Dr. Demi's point, we need to continue to develop representational data sets that are used both for training and validation. I mean, AI, particularly the AI that we develop at Eko, are built off of existing data sets on patients that are anonymized, and certainly they consent to be a part of it. But if that training data set is not representative of the population, there's a higher likelihood that the algorithm that comes out of it isn't representative. And so it's been critical to us as developers of AI to ensure that our prospective data collection efforts are representative and diverse, and that we then validate it on diverse populations. And that's something that the FDA has taken very seriously with this new wave of software as medical devices come through, and a priority for us as well.
I was doing a little reading before we started our conversation. There was a study done in the UK on the stethoscope. The participants were all likely to have trouble with their heart. So, is it clear that the smart stethoscope would work as well on the general public?
Great question. The stethoscope can be used on anyone. The particular low ejection fraction algorithm is indicated in the US to be used for patients at risk of heart failure. So either due to age, due to pre-existing condition, or due to pregnancy. And so to answer your question, it wouldn't be recommended that it be used on the mass general population. But if the clinician has any suspicion that this patient may be at risk for disease, it is indicated for use.
As you know, doctor, every study has limitations. Do you think there needs to be broader data needed to justify the stethoscope's use? If so, what might that be?
Oh, absolutely. So the context in which the study was done is also important because my area of interest is in pregnant and postpartum women who may have heart disease, is why I have really been intentional about saying we need validation studies in this patient population. And we've already done some work, like I explained earlier. But this randomized clinical trial was done in Nigeria, which has a high prevalence of disease. I do think there needs to be similar studies prospectively done in the United States before we say that this is ready, because prevalence we know also affects performance of tools, how common the condition is. What about when it's rare? Is the performance of this tool still really good? We don't know that except we do additional studies. And I think we need to understand all of these nuances. If we roll out this technology, how frequently is your OB going to use a stethoscope and examine that patient? Should it be deployed to the OB? Should it be deployed to our nursing staff when they come in and they're doing vital signs, getting a blood pressure? And also, what is the downstream impact if we get false positives? How often are we getting an echocardiogram? What is the impact on healthcare costs? And I think that those are important questions that we still need to answer.
I'm curious, how do you think this might be accepted by physicians? Dr. Demi, you mentioned, the stethoscope has been in use for what? Couple hundred years, I think, right? And it is the go-to medical tool. It has been. Why do you think doctors would look at this and say, oh, maybe I should give this a try?
I think one of the reasons why physicians might be open to adopting this technology is because it is familiar. It's something that we already use day to day in practice and can essentially replace your existing stethoscope. But if this replaces the regular stethoscope, which you know you will be using day to day, I think that eases the likelihood of adoption. Plus, there's also additional benefits to switch into this technology because, like we mentioned, just getting an ECG on a patient or just examining them is not enough for you to detect that someone has heart failure. And now we are demonstrating in a clinical trial that this is better than just leaning on the clinician's index of suspicion and, gestalt for saying I should get a test or not. And that is really what I feel like a physician wants. So I am optimistic that most will be open to adopting a technology like this.
Although, Jason, you are kind of bucking a lot of tradition when it comes to the old-fashioned stethoscope versus what you've developed.
We really wanted to embrace the tradition, and that sort of is visible in both the form factor, in the fact that it does what a traditional stethoscope does. It amplifies sound, makes it easier to hear, but it sort of layers on. So you can think of what Eko's done for the stethoscope, this analog tool that's been around for 100 plus years, similar to what other companies have done with other tools around the house, like doorbells, which are now smart, and thermostats, which are now smart. I have a smart doorbell at my house, and yes, it rings the door, but it has an embedded security system so that I can see whenever someone's at my house. And we've transformed this basic tool into something that's really powerful. It's still the tool that a 3-year-old will draw when they're drawing the picture of a doctor. It's not going anywhere, but we can we can superpower it.
Again, nothing's ever perfect, right? But what are the challenges that you think you need to, beyond the current study? Is there something else with this technology that you need to iron out that has popped up as it's used in these studies that you need to iron out, perhaps? Anything?
With this current version, it's really around how do we sort of develop the body of clinical evidence. And we know it takes about a decade for new technology to sort of permeate throughout a healthcare system in the United States. And so this technology was in the US FDA cleared in May of 2024. So just a mere months ago. And I think given that recent FDA clearance, we are well on our way. But the goal is to really kind of make this a standard of care. We're about a decade into this journey, and we now have about 500,000 healthcare professionals using our digital stethoscopes. And so to see the vision at UC Berkeley turn into really shepherding in a new era of early heart disease detection, that's only going to be catapulted to the next level with this AI. And so we're just very grateful to investigators like Dr. Demi, who have taken our technology and really thought about really novel, impactful ways to apply it to specific populations. And so the work that the Mayo team has done in Nigeria and is now bringing to the US for maternal health screenings using the low ejection fraction algorithm will not only kind of help demonstrate this use case, but really serve as the launchpad to then deploy that to the 500,000 and eventually, we hope, 1 million providers in the next couple of years that are using our technology. So it's not just AI that's going to sit on a shelf. It's AI that's going to be deployed to the front lines of care through the hundreds of thousands of connected stethoscopes that we have in the field today. And that's translational innovation that we're really proud of.
It was really a pleasure having you both on the program. Thank you so very much.
Thanks, Kathy.
Thank you so much.
Tomorrow's Cure is a co-production of Mayo Clinic and PRX. Our producers are Deborah Balthazar and David Newtown. The show is edited by Genevieve Sponsler. Our sound engineer is Tommy Bazarian. Our theme was composed and produced by Terrence Bernardo. Tony Carlson is our production manager, and our executive producer is Jocelyn Gonzalez. Special thanks to Preston Spire for audiovisual production support. Be sure to follow Tomorrow's Cure wherever you get your podcasts. I'm your host, Kathy Wurzer. Thank you so much for listening.